Intra-aortic balloon pump is a mechanical assist device that increases myocardial oxygen perfusion and indirectly increases cardiac output through afterload reduction. It consists of a cylindrical polyurethane balloon that sits in the aorta. Intra-aortic balloon pump was invented by Adrian Kantrowitz. He was an American cardiac surgeon who performed the world's second transplant attempt on 1967. The intra-aortic balloon is timed to inflate and deflate in synchrony with the cardiac cycle. This counterpulsation increases myocardial oxygen supply and decreases the myocardial oxygen demands of the heart. Intra-aortic balloon pump effects. The inflation and deflation of intra-aortic balloon have a number of primary, secondary, and systemic effects. These parameters should be regularly evaluated to assess the effectiveness of therapy. There are two primary benefits of counterpulsation: increase myocardial oxygen supply with balloon inflation and decrease oxygen demand with balloon deflation. These benefits are based on volume displacement. The vascular system is a closed system with a relatively fixed volume of blood. As a ventricular ejection occurs, the volume of blood in the aorta increases. When an intra-aortic balloon is placed, the balloon will inflate at the onset of diastole. The inflated balloon displaces that blood volume, increasing perfusion to the coronary arteries. Inflation of the balloon will also raise systemic pressure in diastole, an effect known as diastolic augmentation. The intra-aortic balloon remains inflated throughout diastole to maintain this volume displacement. The balloon is timed to deflate just prior to the left ventricular ejection. With rapid deflation, the pressure in the aorta is reduced. This reduction in pressure decreases the resistance against which the ventricle has to work. Subsequently, the systolic wall tension, or the afterload of the ventricle, is also reduced. The reduction in pressure makes it easier for the heart to empty, potentially increasing cardiac output. These effects are reflected by a reduction in aortic and diastolic pressure and the subsequent systolic pressure. In summary, the secondary effects of counterpulsation are likely to include any of the following: improved cardiac output, decreased heart rate, reduced pulmonary artery diastolic pressure and pulmonary capillary wedge pressure, reduced systemic vascular resistance, decreased systolic and end diastolic pressures. Diastolic augmentation. In early diastole, increased mean arterial pressure. The systemic effect of the intra-aortic balloon counterpulsation can be assessed in the nervous, renal, vascular, and respiratory system. Improvement in cerebral perfusion enhances the patient's level of consciousness. Urine output increases due to improved renal perfusion. The increase in cardiac output augments peripheral perfusion, may be evidenced by skin that's warm and pink. And as a cardiac output increases, respiratory status improves. Uniform analysis. Arterial pressure waveform. The hallmarks of the optimal timing include the following: sharp V at the decrotic notch followed by an increase in the diastolic pressure. Diastolic augmentation, that is ideally supersystolic. Reduced aortic and diastolic pressure, which is referred to as assisted end diastolic pressure. Reduction in the subsequent systolic pressure, which is referred to as assisted systole, an increase in the mean arterial pressure. Trigger and timing. When the patient is being supported with intra-aortic balloon counterpulsation, ideally both the electrocardiogram and the arterial pressure waveform are monitored on the pump console. These signals enable the pump to identify the phases of the patient's cardiac cycle. The clinician can use these waveforms to assess the effect of therapy. Proper use of the intra-aortic balloon pump requires a thorough knowledge of two important concepts: timing and trigger. Timing refers to inflation and deflation of the balloon in relation to the patient's cardiac cycle. Timing can be visualized on the arterial pressure waveform. Trigger is the physiologic signal from the patient that identifies the beginning of a new cardiac cycle. An electrocardiogram is the preferred trigger source, since an electrical impulse precedes and initiates the mechanical event. The R wave on the electrocardiogram represents the onset of new cardiac cycle and is referred to as the trigger event. In circumstances where the electrocardiogram is not available for use as a trigger, the arterial pressure may be used to maintain synchrony with the patient's cardiac cycle. Pump timing errors. Timing errors include early or late inflation and early or late deflation. Let's examine the effects of each of these errors. Early inflation occurs when the balloon is inflated before the aortic valve has closed. Inflation is evident on the waveform before rather than at the necrotic notch. Diastolic augmentation encroaches onto the systole and may be difficult to distinguish between them. Early inflation can have a number of physiologic effects. The aortic valve may close prematurely. There may be increases in left ventricular and diastolic volume and pressure, or pulmonary capillary wedge pressure, as well as left ventricular wall stress, or afterload. Aortic regurgitation may occur. Inflation of the balloon a marked amount of time after the aortic valve closes is considered late inflation. On the waveform, inflation appears after the necrotic notch. There is a notable absence of sharp V. The results of late inflation include insufficient levels of diastolic augmentation and coronary artery perfusion. Deflation is considered to be premature when the intra-aortic balloon is deflated during diastole. This error seen in the waveform as a sharp drop following diastolic augmentation. Assisted aortic end diastolic pressure may be equal to or less than the unassisted aortic end diastolic pressure, and assisted systolic pressure may rise. As a result, coronary perfusion is not optimal, and there is a potential for retrograde coronary and carotid blood flow. Angina may occur as a result of retrograde coronary blood flow. Afterload reduction is suboptimal, and myocardial oxygen demand may increase. Late deflation occurs when the balloon remains inflated after systole has begun. On the waveform, assisted aortic end diastolic pressure may appear greater than unassisted aortic end diastolic pressure. The rate of rise of assisted systole is prolonged, and diastolic augmentation may appear widened. At the physiologic level, afterload reduction is essentially absent. Myocardial oxygen consumption rises as the left ventricle ejects against a greater resistance in a prolonged isovolumetric contraction phase. The intra-aortic balloon may impede left ventricular ejection and increase afterload. It is important to note that when a reliable trigger is maintained, the algorithms in the pump will recognize the onset of a new cardiac cycle and trigger deflation of the balloon if a new cardiac cycle begins before the balloon is timed to deflate. This prevents the balloon from remaining inflated during a systolic event.